Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the fern.org website or on our YouTube fern.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. Our dizziness etiologies and diagnoses. Dizziness, as defined by Merriam-Webster, it's an adjective meaning foolish or silly, but it also, from a medical sense, is the having a whirling sensation in the head with a tendency to fall based on the dizziness. It also can suggest being mentally confused. What are our pathologies for dizziness? Systemic causes such as fluid loss, electrolyte imbalance, low hemoglobin, or blood pressure changes can cause dizziness. Peripheral causes, specifically vestibular dysfunction, can also cause dizziness. And then there can be central causes of dizziness, including CNS ischemia, particularly posterior ischemia, and it can be related to CNS events like TIAs or CNS lesions, and we will address all of these during this presentation. What is the normal vestibular anatomy and mechanism? If you go to Figure 2, page 4 of the monograph, you can see the structures that are related to the vestibular peripheral system. The utricle and saccule sense vertical and horizontal acceleration. Our three semicircular canals sense movement in three directions. Our vestibular nerve carries the input from the vestibular system or the peripheral system to the brain from the periphery. Our dizziness case studies. Let's consider a few cases that are relevant to our practice of emergency medicine and the treatment of patients with dizziness in the ED. The first is a 44-year-old dizzy male, and you receive sign-out from your colleague who says, just check the CT. It's a 44-year-old male who's previously healthy. He's had 6 hours of continuous dizziness. He appears to be a little unsteady. He says, I'm feeling like I'm drunk, but he has normal vital signs. He has some left beating nystagmus with gaze to the left. And your colleague says, look, if a CT is okay, send him home with some meclizine. Let's think about that, and we'll consider the case conclusion at the end of this lecture. Another case, a lightheaded 70-year-old. This is a 70-year-old female who's had lightheadedness for 5 days. She says it's worse when she gets out of bed. The dizziness appears to wake her up out of her sleep. She will awaken and then feel dizzy in bed. She's got a history of hypertension. She's on cholesterol and blood pressure meds. Her vital signs are okay. She has a normal neurological exam and no nystagmus. Should a CT be ordered, and why? A third case, a syncopal 58-year-old. This is a 58-year-old male, diabetic, with nausea and vomiting 3 times today. Syncope was reported, but was such bad vertigo, he had to lower himself to the ground. So he didn't actually pass out. He just said he was so dizzy he had to put himself on the ground. This began 3 hours previously. It was sudden. He has nystagmus to the right and higher amplitude gaze to the right. His HIT test is positive. Skew is negative. He is mildly unsteady but has normal gait. Should you call the stroke team? I understand there's a lot of information in this brief presentation, but we will cover it today in our lecture. In conclusion, the ATTEST system for the evaluation of the dizzy patient includes the following: A, associated symptoms; T, timing and triggers; ES, examination signs; and T, confirmatory testing. ATTEST. When evaluating an ED patient with dizziness, please consider the following. Using the ATTEST system for evaluating ED dizzy patients, those patients with acute, severe, continuous symptoms should be considered to have acute vestibular syndrome. Patients who have intermittent symptoms or non-continuous symptoms at the time of evaluation are noted to either have triggered or spontaneous episodes of dizziness and vertigo. Topping the list of diagnoses using the ATTEST system are orthostasis, BPPV or benign paroxysmal positional vertigo, and posterior stroke. BPPV can be diagnosed with the Dix-Hallpike maneuver and can be treated with the Epley maneuver either in the emergency department or in follow-up. It is noted that you should evaluate patients with caution in the setting of the COVID-19 pandemic, as the COVID virus can cause neurological symptoms and/or can complicate those neurological symptoms because of poor PO intake and dehydration, which can cause orthostasis. Electronic medical record templates and dot phrases can help to make the exam process more systematic and easily accomplished using the ATTEST system. When evaluating dizziness patients in the emergency department, the following is recommended. Understand that the dizziness pathologies using the ATTEST system fall into 3 diagnostic strata and basically involve 6 diagnoses and 3 specific treatments for those diagnoses. Also recommended is that you study the nystagmus findings, significance, and BPPV maneuvers, Hallpike and Epley, online and in the monograph from which this lecture was obtained. Also, create EMR templates and dot phrases to exclude posterior stroke findings in your dizzy patients in the emergency department. Explain the etiology of the dizziness, including the diagnosis and treatment, and provide appropriate referral for patients with dizziness, explaining to them symptoms which should cause them to come back to the emergency department for repeat evaluation. Lastly, utilize caution when evaluating dizziness patients in the emergency department in the setting of COVID-19, as this virus has both neurological complications and symptoms and can cause orthostasis due to decreased PO intake. If you have specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you to go to the fern.org website for more content related to this educational program and other content related to the care of patients who present to the emergency department with acute illness and injury related to neurological emergencies. Thank you for your participation in this FERNE educational program.